All right, if you're a pharmacy graduate gearing up for the PBC MCQ exam, you've come to the right place. This is your deep dive into multiple sclerosis. We're going to cover everything from the basic science of MS all the way to the nitty-gritty of therapeutic strategies. Let's jump right in.
So here's our game plan for today. We'll start with the fundamentals, what MS is. Then we'll talk about diagnosis and what we're aiming for with treatment. After that, it's all about the therapies, the different approaches, and the drugs themselves. We'll finish up by covering some critical risks in special situations, like pregnancy and breastfeeding.
Okay, first things first. What exactly is multiple sclerosis? To really get a grip on the treatments, we have to understand what's going wrong in the central nervous system to begin with. At its heart, MS is an immune-mediated disease. Basically, the body's own immune system gets confused and starts attacking the myelin sheath. That's the fatty, protective layer that insulates nerve fibers in your brain and spinal cord. The best analogy is the plastic coating on an electrical wire. When that myelin gets damaged, the nerve signals get slowed down, scrambled, or just stopped altogether. And that's what causes all the different symptoms of MS. It's really key to remember that MS is often seen as a two-phase disease. It can kick off with a big inflammatory phase, and then, over time, it can shift into a more degenerative phase where you start to see actual nerve loss. Understanding this two-part nature is crucial for how we treat it.
So why is this topic so important for anyone practicing pharmacy in Canada? Well, look at that number. Canada has one of the highest rates of MS in the entire world. We're talking about 250 cases for every 100,000 people. So for you, it's not a matter of if you'll see patients with MS. It's a matter of when and how many.
So what causes it? There's no single easy answer. It's what we call multifactorial. There's definitely a genetic piece of the puzzle. If you have a first-degree relative with MS, your risk goes up by about 5%. But genetics alone don't tell the whole story. It seems to be an interaction with environmental triggers. Things like low sunlight and vitamin D levels, or having had certain viral infections in the past, like Epstein-Barr virus, are strongly linked. Even lifestyle factors like smoking play a role, not just in risk, but in making the disease worse.
It's super important to know that MS isn't just one single disease course. The very first episode of symptoms is often called a clinically isolated syndrome, or CIS. But the most common type at diagnosis, making up about 85 to 90% of cases, is relapsing remitting MS, or RRMS. This is where patients have flare-ups or relapses, followed by periods where things are stable. Now, over many years, a lot of people with RRMS will transition to secondary progressive MS, where their disability starts to get steadily worse. And then you have a smaller group, maybe 10–15%, who start with a steady progression from the very beginning. We call that primary progressive MS. The big takeaway here? Most of the drugs we have are designed to fight the inflammation in the relapsing forms of the disease.
Okay, so we've got a handle on what MS is. Let's switch gears and talk about the clinical side, how we diagnose it, and what our main goals are once we start treatment.
Diagnosing MS is kind of like being a detective. You have to put all the clues together. The absolute cornerstone of diagnosis is the MRI. It lets us actually see the lesions in the brain and spinal cord. Officially, the diagnosis relies on the McDonald criteria, which requires proof that these lesions have appeared in different places over a period of time. We also use other tests to support the diagnosis, like looking for something called oligoclonal bands in the cerebrospinal fluid. And just as important, we run labs to rule other things out. A classic clinical pearl for exams, a simple vitamin B12 deficiency can look a lot like MS, so we always check for that.
So when we start a patient on treatment, what are we actually trying to do? The goals are really crystal clear, and there are 3 of them. Number 1, we want to reduce relapses, make them happen less often and be less severe. Number 2, we want to slow down the underlying disease progression. We can actually see this on MRI scans by looking for fewer new lesions and less brain shrinkage over time. And of course, the ultimate goal, number 3, delay permanent disability. We want to keep our patients as functional as possible for as long as possible.
With those goals locked in, let's talk strategy. How do we actually manage MS? We'll look at treating the acute flare-ups and then the bigger picture, long-term philosophies of treatment.
Okay, so a patient is having an acute relapse. Our job is to shorten it and make it less severe. The go-to treatment is a short blast of high-dose corticosteroids. For a long time, IV methylprednisolone was the standard, but we now have great evidence showing that high-dose oral prednisone works just as well. The main reason we might still use IV is if a patient just can't tolerate that much prednisone orally. And here's the absolute most important pearl to remember. These steroids help with the acute attack right now, but they do nothing to change the long-term course of the disease. That's a job for the DMTs.
Now, for the long game, there are really two main philosophies. The classic approach is what we call escalation therapy. You start with a safer, less powerful first-line drug. If that's not enough to control the disease, you then escalate to a stronger but potentially riskier drug. The other approach, which is gaining a lot of steam, is early intensive therapy. This is the idea of hitting the disease hard, right from the very beginning, with a high-efficacy therapy. The thinking is you want to prevent irreversible damage before it even happens.
And this algorithm here shows you exactly how that escalation approach works in the real world. You start a patient with RMS on a first-line DMT. Then you monitor them. Is it working well? Are they tolerating it? Great. You continue. If they have side effects, maybe you switch to another first-line drug. But here's the crucial step. If the disease is still active, meaning they're still having relapses or new spots are showing up on their MRI, that's your signal. That's when you know it's time to escalate to a second-line, high-efficacy therapy.
All right, let's get into the real meat and potatoes for your exam. This is the heart of MS pharmacy, packed with everything you need to know. We are diving into the disease-modifying therapies, your essential pharmacist toolkit for MS.
So let's start with our first-line agents. Generally, we think of these more as immunomodulators, not heavy-duty immunosuppressants. They're the foundation of that escalation approach, and on average, they can cut relapse rates by about 40%. That's a huge deal for delaying progression, especially if you start them early.
Let's break down these first-line options. We've got the injectables that have been around forever, the interferons and Glatomira. For interferons, you'll be counseling patients on how to manage flu-like symptoms, and you'll be monitoring their liver enzymes. Glatomira is usually pretty easy to tolerate, but you can get those injection site reactions. Now for the orals. Dimethyl fumarate can cause some flushing and stomach upset, and we need to keep an eye on blood counts. But the one you absolutely positively have to remember for your exam is teriflunomide. The key word here is teratogenic. It is an absolute no-go in pregnancy, and there's even a special washout procedure you have to do with cholestyramine if a patient gets pregnant while on it. So what happens when those first-line drugs just aren't cutting it? Well, that's when we bring out the big guns. We escalate to our second-line or high-efficacy therapies. These drugs pack a much bigger punch against MS, but, and this is a big but, that extra power comes with a higher risk of side effects and toxicity. This slide is dense, but every word is gold. Let's walk through it. First, the S1P modulators, like fingolimod. The big thing here is the first dose monitoring. You have to watch their heart rate for bradycardia. Also, there's a serious risk of the disease roaring back if you stop it suddenly. Next up, natalizumab. The headline here is PML risk. That brain infection we'll talk more about. This requires regular testing for the JCV antibody. Then there's alemtuzumab. It's incredibly effective, but it can cause the immune system to create new autoimmune diseases. It's so serious you have to monitor patients for 4 years after their last dose. The anti-CD20s, ocrelizumab and ofatumumab, work by wiping out B cells, which raises infection risk. And remember, ocrelizumab is our only approved drug for primary progressive MS. Finally, there's cladribine, a unique oral therapy given in short courses. Its main risk is wiping out lymphocytes, which can lead to infections like shingles.
You know, this quote here really captures the art of modern MS care. It's not about just picking a drug for today. It's about playing chess, not checkers. You have to think about where the patient is now, where they want to be in 5 or 10 years, and how each of these drugs fits into that long-term plan.
So let's build on those safety issues. We're going to drill down a bit deeper into the risks of immunosuppression, especially that scary one, PML, and talk about other key parts of care, like vaccines.
You know, a really practical way to organize all these drugs in your head is by how much they suppress the immune system. The really powerful cell-depleting therapies like alemtuzumab and ocrelizumab are in our highest risk bucket. The oral drugs usually fall into that moderate risk category, and then our older injectables plus natalizumab are considered lower risk. This isn't just academic. It has direct, real-world consequences for infection risk and how we manage vaccinations. Okay, I've mentioned PML a few times now, so let's be very clear about what it is. It's a rare but truly devastating and often fatal brain infection. It's caused by the reactivation of a common virus called the JC virus. Most of us have this virus lying dormant in our bodies, but in someone whose immune system is suppressed in a specific way, that virus can wake up and attack the brain.
So which drugs should make you think PML? Number 1 with a bullet is natalizumab. It has the highest and most well-understood risk, and that risk goes up with 3 key factors: being positive for the JCV antibody, being on the drug for more than 2 years, and having used other immunosuppressants in the past. If a patient has all 3 of those, the risk becomes pretty significant. We have seen some rare cases with other drugs, but it's much, much less common. And importantly, drugs like gladiateramir and interferon have no known risk of PML.
Okay, so if the PML risk with natalizumab is so serious, how do we manage it? Well, our main strategy is testing for that anti-JCV antibody before we even start the drug, and then periodically throughout treatment. This lets us sort patients into high-risk and low-risk groups. For those in the high-risk group, another strategy that's becoming more common is extended interval dosing, so giving the infusion every 5 or 6 weeks instead of every 4. It seems to lower the risk without losing effectiveness.
Vaccinations are a huge part of comprehensive MS care, and you need to know the rules. Rule number 1, timing is everything. Ideally, you want to get a patient all caught up on their vaccines 4 to 6 weeks before starting a new DMT. Rule number 2, and this is a massive safety point, live vaccines are a no-go for patients on drugs that cause moderate to high immunosuppression. And finally, a good general rule of thumb is to never give any vaccine while a patient is having an active MS relapse.
All right, for our last big section, let's turn to a very important group of patients, those who are pregnant, planning to start a family, or are breastfeeding.
Managing MS during pregnancy is all about careful planning. Here's something interesting. The disease itself often calms down during pregnancy, but there's a well-known risk of it flaring up in the months after delivery. From a pharmacy perspective, what you absolutely must know are the drugs that are contraindicated. Teriflunomide, cladribine, and the S1P modulators are all known to be teratogenic. For patients who need to stay on treatment, the safer options like interferon and gladiateramir can be considered after a careful discussion. And if a relapse does happen during pregnancy, we can use corticosteroids, but we try to be extra cautious in that first trimester.
Now here is a critical warning, a huge red flag you need to be aware of. While we stop many DMTs for pregnancy, stopping fingolimod and natalizumab specifically can cause a massive rebound of the disease. Sometimes it comes back even worse than it was before they started the drug. This is so important to consider when choosing a therapy for someone who might be planning a family.
So, what about after the baby is born, during breastfeeding? Well, some evidence suggests that exclusive breastfeeding might actually help protect against those postpartum relapses. Because of this, and to avoid exposing the baby to medication, most doctors prefer to stop DMTs while a patient is breastfeeding. But if someone has very active disease and really needs to be on a treatment, our safest bets are those older injectables, gladiateramir and interferon.
Okay, let's wrap this all up with some high-yield therapeutic tips to take with you. Number 1, treat early. All the data shows that starting a DMT sooner leads to better outcomes down the road. Number 2, vitamin D. All patients with MS should be supplementing. Number 3, remember that rebound risk. Never abruptly stop fingolimod or natalizumab. And finally, number 4, know the limits of our drugs. Most of what we have works best for relapsing MS, not for the progressive forms of the disease.
And I want to leave you with a final thought about the future. For years, that cautious, step-by-step escalation approach has been the gold standard. But as more and more evidence comes out showing the long-term benefits of hitting the disease hard and early, you have to wonder if we're on the verge of a major shift. Will early intensive therapy become the new normal, even for patients who don't seem to have aggressive disease at the start? It's a huge question, and the answer will definitely shape the future of MS care. Thanks so much for joining me on this deep dive.